I'm Michele Samorani. I'm from Santa Clara University, and I will talk about how to mitigate no-shows with machine learning and optimization. I'll briefly talk about machine learning-driven overbooking, and then two experiences that we had. One is an unsuccessful implementation at a mental health center. We learn from failing, and a successful implementation at a legal center. So this is not overbooking, right? You have, let's say, 6 patients. They're scheduled once every half an hour. And what if just 2/3 of them show up? Then you have 2 not showing. The doctors would be idle. So that's bad. That's why typically clinics overbook. Overbooking consists of putting more patients in a slot so that if a third doesn't show, then you have the right amount of patients showing, right? In this case, you have 6 slots and you have 6 patients showing. You pay some cost. The cost is this patient here in blue, which is going to wait for half an hour because, of course, the other one was in the same slot. This is a lucky case. You can be unlucky. This is the same schedule, but what if these patients don't show? Then everyone shows up at the end, and as you can see, you have these 5 patients at the end. They take half an hour each. That means that some of them will wait for a long time, and the doctor also will go overtime. So overbooking is very variable in its performance. Perhaps it's good on average, but you have some bad days if everyone shows up. The goal is to minimize the expected waiting time of the patients and overtime of the doctors with different weights to give a different value to both. And setting this weight, as I will touch upon later, is very critical. So the question is, can we predict whether each patient will show up? And can we use this prediction to optimally overbook appointments? And I understand that Mike is working on that, and so is Epic. So here's the idea. You have an appointment request, and this is your current schedule. You have to assign this patient somewhere, and you use some machine learning tool to predict the probability of the patient showing. So in this case, this patient is very unlikely to show. And you use an optimization model, which I'm going to not cover the details of, which decides where to put this patient, for example, in the last slot. Without no-show predictions, I'm not sure if you can read these numbers, but if these patients have all a 68% show probability, this is the best way to schedule them. However, if you had used the machine learning to predict the individual show probability of each of them, then you would have different numbers there. Some of them have a 20% chance of showing. Some of them a 99% chance of showing. So what is the best way to schedule them? It's different. Well, first of all, we have a 99% chance patient in the first slot by themselves. You don't need to overbook that person because they're going to show. So the overbooking is slightly different. And in this working paper, we're showing that actually the costs of the schedule can decrease a lot. So this is very good to do. So we tried to implement this at a mental health center. This work was in collaboration with Linda Laganga from the Mental Health Center of Denver. We worked with a nonprofit organization, right, that provides mental health care to low-income patients. So they cater really to the lowest income patients. Many of them are homeless. The show rate is only 68%. So what are the solutions to this no-show problem? Can they charge the non-showing patients? No. Can they do reminder calls? Yes. They do that, and that's why they get 68% show rate. It probably would be even lower. They could use open access, but the no-show rate for same-day appointments is still high. So they were interested in this machine learning-driven overbooking idea, and also to understand and address the causes of no-shows. So in our simulations, we could reduce the cost of schedules at the mental health center by 8%, and most importantly, we could reduce the occurrences of long waiting times. So this chart here shows the maximum waiting time. So what is that? For each day, I'm looking at the unluckiest patient, the one who waits the longest, because that's really what matters when it comes down to threats at the front office or people that go crazy. So as you can see, without machine learning, you have some bad days, this red bar. Why? Because sometimes everyone shows, because you didn't schedule them properly, right? But with machine learning, you ensure that it never happens almost that in a day everyone shows. So that's why you get a lot less waiting time, and so does overtime. Overtime for the doctor, of course, that's also important. Without machine learning, sometimes the doctor has to wait over an hour. And that has a cost that cannot really be easily captured by mathematical models, because a doctor, if he has to wait for an hour every 2 weeks, they probably quit after a month. So that's also a cost that is kind of hard to quantify. Of course, with this project also comes identifying the causes of no-shows. So we use the database of the center, which has different tables. Here's a relational database sort of view. We have appointments. Each appointment has a staff member. Each staff member has many appointments. Each appointment has a patient. A patient has many appointments, and so on and so forth. Instead of using traditional statistics where you have to pick and build your own predictors, we used a method called propositionalization, which constructs automatically all predictors and allows for new knowledge to emerge, because you don't have to decide which are the suspected causes of no-shows. It finds it for you. Some of them are the usual suspects. Lead time to appointment, which is the time between when the appointment is requested and when it actually happens. Of course, the shorter, the less likely to no-show. The previous no-show history, other important predictor. People that didn't show in the past are not going to show in the future. Interestingly, our machine learning algorithm could find that provider information matters too, not just the patient. It's the provider's history that actually could determine no-shows. For example, the number of times that a provider was at a specific location matters with no-show. Providers that used to work more in community settings rather than the regular clinic, they had higher show rates. A community setting could be a school, a church, a DMV, the homeless shelter, the food bank. They would meet them there, and they would have a higher show rate that way. The specialty of the provider is also important, and interestingly, the no-show rate of the appointments of that provider, right? Which might be because the provider has a certain patient's population, or it could reflect the provider's effectiveness in engaging their patients, if they have a lot of no-shows, right? And also information about the provider's patient population. For example, we found that physicians working with court-ordered patients have higher show rates. That's obvious. Court-ordered patients would face legal consequences if they didn't show. They had to show, so they had higher show rates. Okay, we found all these things, some of them more obvious, some of them less obvious. We wanted to implement it, but it did not happen because of integration problems. It was hard to integrate our application, the electronic health record system that they had, and the front office scheduling system it was connected to. It was hard to integrate these pieces. In particular, they found it interesting, but the timing for them was not right because they were in the middle of a transition from a system to another, and they just did not have enough internal resources to allocate to help me integrate my algorithm inside their system. So that unfortunately didn't happen. As a side note on this, I'm working with Shannon Harris, and we have some VA data, and we are trying out this machine learning driven overbooking on 108,000 visits with a 12% no-show rate. Some of the features are lead time, the past no-show history, and the age of the patients, and whether they have multiple appointments. In our simulated result, we can dramatically decrease the cost of scheduling in these settings. So perhaps we can talk more later about this. I can give you the paper. So that was an unsuccessful implementation. Let me go to the good news. This is a successful implementation at a legal center. This is the Edmonton Community Legal Center in Canada. This is in collaboration with Mohammed Soltani at Wisconsin-Madison and Bora Colfall at University of Alberta. It just got accepted at EJOR. So this has nothing to do with healthcare, but it has striking similarities to a mental health setting in healthcare. So let me tell you more about this. Here we have lawyers who volunteer to provide free legal consultation to low-income customers. A lawyer has a full-time job during the day, and they can volunteer once a month, whatever they can, in the evening, 6 to 8 p.m., to give free consultation to people that are low income. here we have a different setting. We have multiple identical providers in the sense that you had an appointment, but you don't know who you're going to meet. It doesn't matter because most likely it's just a one-time appointment, and all providers know how to deal with common legal issues. The challenge was highly variable service times. Show rate was only 75%. Our scheduling procedure was based on some Markov chain model. And so we had the kickoff meeting with them. We were all excited about the implementation. And at the kickoff meeting, one thing that you have to decide is the relative importance of customer waiting time versus overtime of the doctor. How many dollars is 1 hour of lawyer's overtime? You could sort of quantify that, but how much is a 1 hour of waiting time of the patient? And of course, at this meeting, the patient has no say whatsoever. It's just us with the people. The patient has no say in that in how much their time is worth. So we set that, and we set it wrong in the first iteration. But this is the scheduling procedure that we gave them. So let me tell you a bit how to read this table. This says if you have 4 lawyers on a certain day, and you have, say, you need to have 16 clients scheduled, 7 in the first slot, 3 in the second, 4 in the third, and so on, right? So that's how it was working, and how to schedule people sequentially was pretty simple. Schedule 4, the first 4, you schedule them in that slot, then if someone has calls, put them there, and then you build it sequentially, trying to arrive at this one, and then you should stop because otherwise it's too full, and then the cost starts increasing, and you don't want that. So we gave it to them, and they actually could sort of follow it, not 100%, but they were at least inspired by this table. And unfortunately, because we set these waiting time costs in the wrong way, there was huge waits, high pressure on lawyers in the front desk, the place was packed, there were a few incidents in the lobby, and they tried our schedules for 2 to 3 weeks, and they stopped. We realized that we all underestimated the value of the patient's time, actually. So what we did is that we did a second iteration. Luckily, they allowed us to do it. They were very courageous. And we re-optimized the schedules after attributing a larger value to the customer's waiting time. It's very simple. You just increase that number. You say the customer's waiting time is twice as valuable as we thought. And you get new schedules. So the table that I showed you before changed. And they implemented our schedules, and everyone was happy. They got a 15.5% reduction in the scheduling cost. So they were happy about that. So it worked out just fine. So this is my last slide. A little bit of summary of challenges for real-world implementations that I faced. So setting the cost of patient waiting time, this number is very consequential. And as I said, the patients don't participate to the meeting where this number is set. They have absolutely no voice in this. And then another thing is expected results versus worst-case results. Many academic papers look at average expected waiting time, expected overtime, but what matters is the long waiting times, because patients are going to complain a lot more if they wait 2 hours rather than 10 patients wait 20 minutes, right? And integration with existing software, that was a tough one. Of course, we need resources. You need resources with the client to be able to do that. And there was some resistance to change. Schedulers typically do not want to change the way they operate. I mean, in general, no one wants to change their job, like the way they do their job, and so do schedulers. They want to have the minimal change possible. So things have to be done very incrementally. Okay, thank you very much for your attention. That's all.
Tomorrow I will share with you some of the no-show that we implemented in the hospital that is successful. But this is great. It's really wonderful. I think the value of patients' time is absolutely very important. And we saw that in Tanzania, even in Tanzania, where we can reduce the time. So I think some of these issues really great. And I know you guys have lots of experience that you want to make comments. So, yes.
So that was really, you're very funny. I thought that was cool. You remind me of a guy on TV. You mentioned that there could be factors why patients are repeatedly not showing. You said maybe it's the doctor, maybe it's the patient. I'm always curious with these things whether you have any information on what was done about that. Did for example, the patient with a predicted high probability of showing didn't show? Did somebody call up and say what's wrong, or if they can? What's done to remediate, in other words?
Yeah, thank you, Don, for the question. This is a good question, and actually, I know I actually talked about it with Mike before this, so I'm going to quote him on this. What they can do is doing target reminder calls for the most likely not to show, or or insisting more in reminding them. But it's definitely, you're right. Here I focused a lot on the optimization part of it. So what do you do with these different probabilities of showing? But there is the other face of the medal, of course, is, well, now that you know the causes of no-shows, how do you address them? So in the case of the provider that has a lot of no-shows, a good idea is to talk to them and ask them insights. Why do you have all these no-shows, right? And so on.
Yeah, I mean, reminders are like that's a sanitary thing. It's hygienic. So, I mean, maybe the harvest failed and he's in receivership because of the number 45 tariffs on China. And you have to figure that out to really have the patient see his or herself in this process.
Thanks for the opportunity to comment. I just wanted to say that a couple of things. One is that in my experience in the past, no-show rate not only varies by providers, but it also varies by schedulers. And I'm really interested in this, how to make a good appointment stuff. Sometimes schedulers are able to communicate with the patient in a way and the staff in a way that results in a successful appointment, and other times they may not do that. So I think there's a lot to this human interaction part of actually keeping appointments. We also know from the literature, right, that certain people are more apt to no-show than others. And so I think we as a system need to change our behavior when it comes to interacting with young men who have appointments a long ways in the future, which are the most likely to no-show in our system, right, versus perhaps some other people who always show up. So we got to customize our care, I think.
I like that. I think if Mark is here, he's going to mention that. I think you mentioned about the scheduler, exactly. Sometimes they take the third possible slot, and we never understand why that is actually a measurement, right? This is one of the measurement, but then we always ask why the third, right? So, and I think it affects the patients in terms of whether they feel like they show up or not. But I think this is a really good, and it's really the metrics about what is important in terms of their time, and why do you give them the third possible slot instead of the first one that they want to choose?
Well, and the schedulers know the patient's transportation, their home system, the situation in the clinic, and they can help match it.
Yeah, exactly.
I think make that fine tuning.
Yeah.
Yeah.